and Dr. Diwatia. It's a continuation of your topic, the future of critical care. So let me start with, this is the need how we identified in 2014. So a team of 6 people that includes an electronics engineer, a product designer, a couple of doctors, and the business guy. So altogether, so this came to the emergency department in St. John's Medical College, Bangalore, where I was working at the time. So then we came up with a methodology, so that is in parallel with the Stanford Biodesign program. So how to actually identify a need? Because if you ask any doctor, like, what is there to invent? So you have, every doctor have, multiple needs. But what is that need? I mean, is it exactly the right thing or to work on and then come out with a device? And especially in Indian sector, we have less, innovations in medical devices. And I'm happy to be a part of the device. And now, we did need identification following the Stanford Biodesign program. So we followed up in ICUs, we followed up 108s, primary healthcare centers, and we talked with multiple nurses, nursing staff, all the paramedics, everyone. And we have come out almost 120 plus needs in a span of 2 months. And then the question was, do we really have to work on all these 120 needs? And then we have our own filters. Then we filtered all of them, and then these were identified in almost like 22 areas. And then finally, we have come up with the top need after all the filtrations. And the top need was ventilator-associated pneumonia. All right. So now, ventilator-associated pneumonia, okay, as you know, I'm not going to teach you all the academics of this ventilator-associated pneumonia, but rather I would tell you the gaps, what we have identified in preventing this major problem. And now, it's just the basics of VAP. Okay, it's still a leading problem. And you have all the pathogenesis. I'm not going to talk about it much. The current care, which includes the VAP care bundle. I'm sorry, but it's... It's not changing. It's not changing. So this is where we have worked in various places. Okay, so and we have come out with various needs, as I mentioned, about 120 plus needs, and then come out with the final top need of ventilator-associated pneumonia. Now here, as I told you, so these are the current care, so that includes VAP care bundle, and then we have multiple current cares. But what I wanted to focus is challenges that we regularly face in ICUs. Now say suctioning is a blind procedure. Okay, so why I'm talking about suctioning, about the secretions, we said that, okay, one of the main cause, like there are multiple other causes, one of the main causes is trickling of the secretions down to the trachea. Now what are the gaps here? Suctioning is a blind procedure, you ask a nurse to do it. So it depends on the skill of the nurses. It's highly dependent on the skill of the nurses. You ask an experienced nurse to do it, yeah, she can do it very well. But you ask a newbie who's come to it, and she is literally afraid even to touch it. There are many experiences where we have even watched, we have observed by standing far, almost like 100 to 150 nurses, how they're actually doing and how to find out the gaps. And we were just standing and then watching, and some of the nurses even said, so please go away, I cannot even do that if you're standing here. Okay, fine. Now what are the things that we actually observed? Okay, so if you talk about a new nurse or is new entrant into the ICU, so she's literally afraid to manipulate the patient's position and then try to suck out the secretions from the oral cavity or the oropharynx. Whereas sometimes some nurses, when you stand, sometimes we have even observed that some nurses keep on suctioning, and then I have observed, like, even some tinges of blood start coming in. I said, stop, it's finished now. So there is no a specific way to say when to stop and then how to stop. It is totally skill dependent. And as you can see, so there are, the mouth is completely tied up with all the tubes, and then it's completely covered. And then what are the other things? Now we have Indian sector, it's highly understaffed. And then disparity among the nursing practices, lack of written oral care policies for the intubated patients. As one of the doctor actually mentioned, we have policies in place, but how often do we actually follow and implement uniformly across the globe? So not only in India, across the world, we have observed that oral care practices are not being followed properly, and the disparity between actual nursing practice and documentation. But if you practically go and see what exactly happens at the end of the shift, 2 o'clock, you wanted to see a patient, so they are busy nursing. What are they doing? So they are going to hand over, they want to write up, jot down everything, whatever they have did. Okay, the sister did do the section? Yeah, finished. You go see that, all the documents are full. But we actually don't know. So many times it happens that, okay, we don't try to, our sisters may even forget. Sometimes there is an emergency case or some kind of a resuscitation happening. So sisters might miss some suctioning as well as oral cleansing part. Then, lack of recommended oral cleansing every 2 to 4 hours. I asked one question to one of my friends in US as well. One of the, say, in the suburbs, said, how often you do this oral cleansing? He said, maybe 12 hours a day. Twice. Even there, we say that, okay, if we think that it's affluent country there, so we, as a practice says, around 3 to 4 hours of oral cleansing is required by an antiseptic. But still, we follow only 12 hours. But in India, I really don't think so. It happens only once in a day, especially at the time of, and early in the morning, 4 o'clock, they want to change everything. Yeah, they'll do it. That too, how do they do it? They are really afraid to open the mouth. The actual procedure is to open the mouth, clean, brush, and then give an antiseptic solution, coverage across all the surfaces. That's what is required. But here we don't do it much. They'll just dip a gauze piece, possibly they'll just put inside and remove. That's the care that we actually give in most of the cases. I'm not talking about few specific good ICUs. Okay, then the cross-infection from the caregivers. And then it's been noted that automated suctioning aspirates more than 10 times more secretions than the normal suctioning. And then there are evidences, even continuous aspiration of the subglottic suctioning, so also reduces the incidence of VAM. When we are trying our device, I'll just come in a few next slides. What are the other challenges? Okay, now coming to the suction pressure as well as flow rate. We have taken a small survey across Hyderabad, around 15 to 20 hospitals, and observed that the flow rate varies at anything between 25 liters per minute to around 60 liters per minute. That is the flow rate. And what is the wall mounted pressure or the vacuum apparatus showing? It's somewhere between 200 at the least to the 600. You ask the sister to do it, yeah. They'll just disconnect the vacuum source, they will not even adjust the pressure, they'll connect it and they'll suckle it with the pressure of around 400 to 600 mmHg, whereas the recommended pressure is only 150 to 200 to prevent any kind of injuries. And with the high flow rates, there's one of the challenges. So keeping all these gaps in mind, we have come up with one solution where the device detects the presence or absence of the secretions by optical sensing technology, and then it does its own intermittent suctioning. All you have to feed is the timing, how frequently it has to be done based on the physician's decision, and it can collect secretions from 3 different areas, dependent areas, specifically oral, oropharyngeal as well as subglottic. We are using this subglottic. We are not intervening the subglottic area, but we are going to use the same a port that is equipped with the subglottic port or just above the endotracheal cuff. So we are going to use that same port. I'm going to show how the device works in short. And it also detects a port block, and it is able to clear the port block. And the speciality of this one is you can adjust the pressure in 3 different areas with the same suction line, one single suction line. So you can adjust the pressure in oral and oropharyngeal areas, you can adjust the pressure in subglottic areas, as well as you can set the timing for the oral lavage. So it does sprinkle an antiseptic solution as per the time, so into the oral cavity, and then once it is sprinkled, after certain retention time, it's going to suck out into the jars. So this is the solution that we have come out. I'll just try to show you some video how actually it works on. So this actually I planned with a very beautiful voice, and then you have to bear with me. Okay, so this is our device in brief, where you can adjust the pressures. Now where you can see that this is a custom disposable that we have developed, and then it goes over any standard endotracheal tube or subglottic tube or associated with subglottic port, and then it goes over it and then fixes into the oropharyngeal area, and in turn these are connected to the vacuum jars or suction collection jars. And when the secretions are collected in 3 different areas, as you can see, they are being sucked out as per the time, and they are collected in 3 different areas, 3 different jars. As well as it can also provide the oral lavage, the rinsing process that is done by sprinkling some antiseptic solution into the oral cavity, and then that goes into the oropharyngeal area. That is again sucked out as per the timing that is fed. Now here you can even adjust the pressures, as I told you. You can adjust the pressures here by manipulating. You can see that. So they are not so clear. Yeah, you can adjust the oral, oropharyngeal as well as the subglottic pressures here, and yeah, that actually prevents injury to the patient as well as it saves a lot of time. So we are from Koyo Labs. Yeah. Now, a big question: why do we consider the device is safe? Now you might say, oh, the device is new, it might cause harm to the patients. How do you think that it is safe? Now, we have designed so that the part, a disposable part that is going into the oral cavity, so that is actually going into the oropharyngeal area, that is almost similar, or it is exactly similar to the OPA that we are going to use. Now you can show you some basic similarities with this. Now you can see, yeah, you can look at the extent of the OPA that is placed in the oral cavity. This is a cross section that we have a model, and that's the area where you have the secretions getting collected here. Then you can see there's a comparison with our disposable over the endotracheal tube and the OPA standing on side. Now where you can see this, that the extent where it exactly goes is similar to the OPA. Sometimes we are not intruding, or we are not going to a new place or new dimension. We have multiple ports for drainage of the suction or secretions that are collected there. Then, so how did we start? We started our journey. So we presented it to the Department of Biotechnology. We have been funded with them, and then we finally got a US patent in September 2017 this year. And then we are conducting the clinical trials in Omni Hospitals, Hyderabad itself, Kottapet. And then we have already applied for CE. Hopefully we'll be getting the CE in the next couple of months. So we're expecting the device to be in the market in the first quarter of 2018. And then to just tell about like how we actually worked, we have been covered by Times Now for series, amazing Indian series, and we have been featured as Hunarbaz and Didi. And then we are winners of Challenge Cup India, that's organized by by the 1776. We represented India in Washington DC. We have been invited to the American College of Cardiology. We are presented as top 14 global innovative healthcare technologies. And then we are only one of the 3 startups from India in Interface Health Societies Canada of top 100 startups. And then there are many more I cannot mention here. And then recently we have been invited to Harvard Medical School in a 2nd annual roundtable conference for mechanical ventilation and airway technologies. And then we have also been invited by Boston School of Business. And yeah, this is where we stand now. So, and thank you very much for listening. So if you have any question, I can take.